Hey friends, let's jump right in. So, we are looking at, you got it, guys. This is acute respiratory distress syndrome. Now, remember, this is not a disease itself, but a symptom or condition of underlying lung pathology. When we're looking at this chest x-ray, yes, we're not radiologists, but as a nurse and especially in, critical areas or not, when we see this, we know that a normal x-ray is black, meaning that there's no blockage. Um, we're looking at a chest x-ray that is what we would call whited out. We are looking at something that could be described as hazy ground glass opacities. And it gets that name because when they make glass, when they're making, excuse me, yes, when they're making glass, the surface of that glass is blasted by sand and it gives the glass like this hazy or frosted appearance. So that's where the name ground glass opacities come from. I'm such a nerd, y'all. I'm sorry. That's just nice to know. But what we're looking at is impaired gas exchange because the chest x-ray is a little hazy or gray due to fluid accumulation. An acute respiratory distress syndrome, you have increased capillary permeability due to a systemic inflammatory response. And in this case, it's due to smoke and inhalation of chemical fumes. Other things that could cause this: COVID-19, sepsis, pneumonia, head or chest injuries, near drowning accidents when water is inhaled. It's vomiting, someone who vomits and aspirates, so aspiration. Um, when there is fluid filling the air sac, you will not have adequate gas exchange at the alveolar capillary membrane, hence the hypoxemia and the respiratory alkalosis. So with this client, it is going to be imperative that we eliminate some of that fluid, we improve gas exchange, and the first thing we would want to do for this client is manage the symptoms as we resolve the underlying cause. The underlying cause was the smoking inhalation of chemical fumes. There's no chemical fumes in the hospital. There's no smoking in the hospital. So, well, we know there's no smoking. So we've addressed the underlying cause. And right now we're going to manage the symptoms. This client definitely needs some type of oxygen. Now, if I give this client oxygen, giving them a non-rebreather, which is delivering 60 to 80% of FiO2, great, dandy. However, there's fluid there. So I can fill you with oxygen, right? But as long as there's fluid impairing that alveolar capillary membrane, that client is still going to be in respiratory distress. They're not going to have adequate gas exchange. So we may need diuretics in this client to eliminate some of that fluid and allow for better gas exchange, thus oxygenation. We can also prone this patient, right, and lay them on their stomach. And when we prone them, that will help ensure adequate lung expansion, thus improving oxygenation. Now, we know a patient with acute respiratory distress syndrome, may need mechanical ventilation. And it's not something that happens always rapidly. So we can prone them, give them some oxygen while we're possibly preparing for mechanical ventilation. And we also prone clients who are receiving mechanical ventilation as well. Now, we talked about we need oxygen for sure. We definitely need some diuretics to remove that fluid. And we're going to do proning and then possibly prepare for mechanical ventilation. We do want to avoid mechanical ventilation in these clients if we can, because that pressure that is being forced into the lung can definitely cause a tension pneumothorax and some baro and volume trauma. So if proning, oxygen, and diuretics can resolve it in a non-rebreather, we definitely want to start there. Nursing, we always start low, we go slow, least invasive to the most invasive. This client is definitely at risk for pneumonia. Anytime you have fluid accumulation, bacteria likes warm, moist places. So we definitely want to check a white count. Um, they're coughing up, they're coughing. So we want to know if that cough is productive. If it's foamy, frothy, pink tinge, whatever the case may be, we want to do a sputum collection as well. With the chest tightness, um, we want to auscultate, and if we heard any wheezing, we need a bronchodilator. It doesn't matter the cause. Anytime I hear wheezing, I know my bronchioles are constricting or closing off. I need a bronchodilator to open up those bronchioles. And anytime I have fluid, I know when I auscultate, I'm going to hear crackles, indicating fluid accumulation, no matter the cause. And I'm going to more than likely need a diuretic to remove that fluid to improve gas exchange. In nursing, we always have to be mindful of the pathophysiology, how it relates to the disease process, and what is the underlying cause. However, sometimes I have to manage the symptoms before I can address the underlying cause. And that is because when we think about airway, breathing, circulation, disability, infection, pain, and safety, and always in that order, it's already an order of decompensation. The respiratory system is going to decompensate um, quicker than it would take for you to get an infection that can travel to the bloodstream, which is sepsis, right? So we may have to always address that symptom before we can address the underlying cause. And in this case, we would need to address his signs and symptoms before we can really tackle removing all of that fluid. It's going to be quicker to prone you, give you some oxygen than it is to try to administer a diuretic IV. We're going to have to, depending on what it is, if we're giving furosemide, et cetera, we're going to have to check that potassium level, make sure that's on, appropriate or adequate before we give you this diuretic. And then we're going to have to hope your kidneys are functioning properly. And you can push a diuretic all day, but if the kidneys are not functioning properly, it ain't going nowhere, right? So, and there's other treatments. Yes, dialysis, yes, continuous renal replacement therapy, but this is Arts. Great job. My whole goal is to get your brain to turning and thinking. And it doesn't matter when you're on that NCLEX and you're looking at those charts and you're approaching a next gen question or a regular question, your brain has to process the way I just broke it down. What is the pathophysiology of the disease process? Think about your ABCs. Think about, am I going to have to manage the symptoms before I get to the underlying cause? Or is the question asking me what the underlying cause is and to address it? Every question is written through the nursing process. It's going to refer to something with patho, health promotion, disease prevention, signs and symptoms, labs, diagnostic, interventions, safety, etc. And as a nurse, that question is written just like it would be if every question is you approaching a patient at the bedside, or client, sorry, in Collect's world, client, approaching a client at the bedside. So put yourself at the bedside, perfect world. Don't read into all of your experiences, but you can play on experiences, but you can't put that whole scenario or your whole experience with a patient that looked like this into one question. So just a little tips and tricks for the NCLEX. I know these videos, I'm trying to keep them short. This one was a little bit longer, but I just kind of want to give you some exposure into what the actual boot camp, the clinical survival boot camp. I'll show you all some insights into that very soon. So hope you enjoyed this question. Let me know your thoughts. And until next time.